Yeah.
Dr. Priya? Yeah, can you try your screen sharing once again?
Yeah, just a minute.
Dr. Selvaraj, are you there? Yeah, we see you, Dr. Selvaraj. Hi, welcome. You're muted. Just asking you to unmute. Can you press the unmute button? Great. So we'll just begin in 2 minutes, everybody. Dr. Abhishek and Dr. Simran, can you please open your videos and unmute once?
Hello, good evening, sir. Good evening, ma'am.
Hi, Abhishek. Hi, Simran. Simran, can you speak once?
Yes, sir.
Perfect. Great. So you can go back to muting again. Dr. Priya, are you able to test your slides, or we'll be able to share from our end if needed?
Can you share from your end? It's not some settings and all, some problem is there.
No worries, we'll do that. Just be muted. We'll start in a minute.
Yeah.
Yeah, Dr. Selvaraj, could you share your screen in the meantime?
Yeah.
We're just waiting for Dr. Subbiah in the meantime. He's joining in a minute, having some connectivity issues as well. While you do that, I welcome everyone, all the live attendees who have come here. I think today, because of some connectivity issues and technical reasons, we are just a bit late, about 4 minutes late now. We'll be beginning shortly. Just bear with us for a couple of minutes.
Srijan, I joined. Sorry for the delay.
Welcome, sir. Welcome. Good evening. Just 1 minute, sir. We are beginning in a minute.
Ziba is there.
Yes, sir. Good evening.
So, Dr. Selvaraj, I'll ask you to wait for a minute. We'll begin with the proceedings here.
Yeah,
And meanwhile, if you can just email us a copy of your presentation in the meantime.
Okay.
Right.
Okay,
Great.
I'm sharing. Is it visible now? Is it visible now?
Not yet. We are sharing the screen right now, Dr. Selvaraj. Yeah.
Okay.
Yeah. Right. So, good evening, everyone. Welcome to today's masterclass. We invite Vice President Dr. Subbiah Shanmugam to kindly deliver the welcome address.
Good evening, all. Happy to see that the younger generation has taken over. I see Dr. Selvaraj, my own student, is appearing there online. As you all know, the general surgical oncology training is in the crossroads. I go to many places as an examiner, and when I see after the compartmentalization of the training, I'm afraid general surgical oncology training may get a beating, because many places where there is a separate department of gynec oncology and gynec oncology, the general surgical oncology training is little deficient in training the candidates with gynec cancers and head and neck cancers. So I feel to fill in the gap, a lot of effort is needed. And an academic body like IASO as it is playing its role for the past few years. this flagship program of this IASO Masterclass series, where the experts, they present and they interact with the IASO members and other participants. And as you all know, cancer cervix, even though it is declining, a lot of activities going on in prevention aspect, still I feel in rural areas we get a lot of cancer cervix patients. And today, I think with the expertise and the information available with Selvaraj and Priya Bhatti, the session will be useful. And I request the organizers to proceed. I will be there online.
Thank you, sir, for the welcome address. General housekeeping instructions for the candidates. Kindly answer to the point, and no one is expected to know all the answers, so there is no harm in mentioning if you do not know the answer. It saves time for everyone and maintains the flow. The examiners keep hinting all the time, so keep an open mind. For the examiners, in the interest of online viewers, please give the expected answers to the questions that are unanswered or answered incorrectly. And please direct the questions to each candidate by their name so we can ensure equal opportunity for both the candidates. For the rest of the participants, you can participate actively through the online chat box and the Q&A section. Now we will start the session. We will be shortly sharing the screen from our end for the mock exam part. I encourage both the examinees to keep their mics unmuted and their videos also on. Thank you. Over to you, Dr. Priya.
Good evening, everyone. I'm Dr. Priya. You all may not know me. So I'm a gynae oncologist. I work at Amrita Hospital, Kochi, and it's a pleasure to be a part of this. Thank you, Dr. Ziba and Dr. Subramaniam, for inviting me. So I have kept 3 cases. I'll be starting with the case 1. Can we have the next slide? So the first case is she's a 54-year-old multiparous menopausal lady belonging to upper socioeconomic class, presented with complaints of spotting PV for the past 2 months. She was married at 24 years of age. She's in a monogamous marriage, and she doesn't give any history of any cervical cancer screenings in the past. So this is her short history. Can we go to the... Okay. So at the history part, can we go back to the history? So at the history part, what are the important things that you'd like to know as far as cervical cancer is concerned? Since we already know we are discussing cervical cancer, so we limit our discussion to that.
Dr. Priya, just request you and Dr. Selvaraj to kindly ask the question specifically to each candidate, because as students, they are just, they won't be proactive in jumping to answer. So just direct your answers, questions to them specifically. Thank you.
Okay, Dr. Simran, would you like to start?
Yes, ma'am. The risk factors for cervical cancer, mostly it is low socioeconomic status, any history of intermenstrual or postcoital bleeding. So the patient has spotting PV for the past 2 months, and since she's never had a cervical screening in the past, then I would like to proceed with that.
What is the age group you would suspect? Like at this stage, you would have differentials of endometrial cancer as well as cervical cancer. So, is there any age-related incidents?
Mostly, I think 40 to 55 or 60 is the age group.
Yeah, so 60 and above, you would think more in terms of an endometrial pathology, and younger than that, it's more likely to be a cervical one. Can we go to the next slide? Dr. Selvaraj, if you have any questions, please go ahead. Okay, so this is a moderately built, nourished patient. BMI is 23. No other systemic findings. Abdominal examination is normal. No palpable lymph nodes. Local examination. So these are the local examination findings. You can see there is an exophytic growth of 3 by 3 centimeters arising from the cervix. Vaginal walls look normal. There is no parametrial involvement, and rectal mucosa and rectovaginal septum is normal on examination. So, who's the other candidate? So, Dr. Abhishek, would you like to tell me how you would actually go about examining a CA cervix patient?
For a CA cervix patient, we'll start with the general physical examination. As mentioned, this is all looks perfectly normal. In the local examination part, I would like to examine the external genitalia region to look for any presence of any discharge and evidence of any excoriation. On per vaginal examination, I will look for evidence of any lesion in cervical, both anterior, posterior, look for any lesion in cornices. Using bidigital examination, I would like to assess the parametria on the both side. In any suspicion of involvement of rectum or part of the vagina involved, like it's involving upper 2/3, lower 1/3 for the local staging part.
Can you elaborate on the bidigital examination? How do you do it?
After the informed consent taken from the patient in presence of a female attendant, after lubricating our finger, we'll put an index finger in the per vagina, and using our second finger in the rectum, we'll go laterally to the pelvic wall as laterally as possible to palpate for any nodularity in induration or thickening palpable. So to assess for the parameter in invasion in the both sides.
What is the stage according to you in this case? Clinical stage?
Clinical stage will be 1B2, ma'am.
Okay. So how would you like to evaluate further?
First of all, I would like to go ahead with taking a punch biopsy from the lesion, perispeculum and the punch biopsy from the lesion, and then I will
Which
go ahead
part
with
of the lesion will you take the biopsy from?
I will prefer taking the biopsy from the edge of the lesion, adjoining the normal mucosal part. Because the central part will be having more amount of necrosis and slough, the edge will be more yielding in the biopsy. And we can even assess LVSI and depth of invasion if possible at the edge of lesion.
That's usually not possible. Depth of invasion LVSI is not possible on a biopsy. That you can see only on a cone specimen. Cone specimen or a hysterectomy specimen. On a biopsy, they can never comment on that. But yeah, because of necrosis, you'll take it from the margins. Then biopsy, you have taken what else? What are the other investigations you'll do to stage? Now, the staging is not clinical anymore. It is pathological and radiological and all of that. So what are the investigations? Dr. Simran, what will you do?
Ma'am, I would like to proceed MRI pelvic.
Okay. What are you looking at? What are you looking for?
The exact dimensions, exact size of the tumor, any involvement of the adjoining structures, the extent of the lesion, and nodal involvement, but CT would be more specific for the nodes.
Is CT more specific or MRI better?
For lymph nodes, CT would be better.
No, they have found whatever studies in cervix they've found MRI is better than CT. Okay, MRI is better than CT and PET CT is better than MRI. So so MRI also gives you soft tissue delineation, very good soft tissue delineation. So adjacent spread, that information is much easier to make out. So MRI is always the preferred Okay, so what else are you looking for? Suppose you don't have an MRI facility, can you do something else?
Ultrasound is the other thing which can be done.
Yeah, an expert ultrasound can be as good as MRI for parametrial invasion. Okay, so you've done an MRI, so it is still 1B2. What will be your plan?
I would like to do a PET CT, ma'am, to rule out any distant mets and to be more certain about the nodes.
No, but you've done an MRI, you have a pelvis with abdomen screening. Why do you need a PET for this? What is the chance of having distant mets in this case?
Slow.
Yeah, PET CT is not indicated upfront for this, for a locally, limited kind of early stage tumor. I mean, you can do basically, I mean, I think people do for everything and anything, but it's not really indicated.
What are the
like this.
indications for doing PET CT scan generally in CS cervix?
Sir, locally advanced
Not in
cervical
CS.
cancer.
Always start with symptoms, symptomatic patients. Any cancer, symptomatic, some abnormal symptom in some other systemic disease system, you start suspecting it, correlate with the local stage. Okay, so symptomatic patient, then locally advanced disease.
Yes, sir.
Or if your MRI is showing, obviously enlarged nodes, involved nodes, or disease which is, more than which is what you have found clinically, then you'll go for a distant mets evaluation. Okay.
How do you suspect locally advanced disease by symptoms? Symptoms of locally advanced disease.
History of back pain or flank pain.
Due to?
Back pain could be due to parametrial involvement or nerve involvement.
Which part of parametrium?
Dorsal parametrium.
Yes, uterosacral involvement. Okay, then?
And flank pain due to hydronephrosis or renal involvement.
Good. Then? Pelvic wall involvement, nodal infiltration. What are the symptoms? Could be heavy nodal burden. What could be
What
the
will they
symptom?
present with?
There could be lower limb pain or weakness.
Pain
Edema?
due to which nerve infiltration?
Obturator nerve.
Yes. Obturator nerve is sensory or motor?
Motor, sir.
How do you test during examination?
Adduction. It causes adduction of the limb.
Okay. So nerve
Adduction and
involvement.
what else?
Adduction and medial rotation.
Okay.
Okay, good.
In this connection, I will ask you, request you to go through the earlier editions of Devita and see what is given as omnious signs of cancer cervix.
Yes, sir.
So the punch biopsy of this patient was adenocarcinoma. This is the IHC P16, negative perf for P53, Vimentin. So why do you think these IHCs have been done? Vimentin, P53, P16.
Dr. Priya, I would request you to direct the questions to the candidate's
Okay.
pen name.
Dr.
We can go to Dr. Abhishek for now.
Abhishek, yeah, Dr. Abhishek.
Yes, ma'am. The IHC for the P16 is done for the association of the HPV with adenocarcinoma. And And the IHC regarding the vimentin estrogen receptor are done to rule out the endometrial adenocarcinoma. That might be the one other possibility.
Yeah. Is there any other IHC nowadays which which you would like to do for use later, or maybe if it's an advanced case?
Simran, would you like to take that?
Ma'am, PDL1 testing.
Okay. What is the relevance of that?
So if it is an advanced disease and we are planning chemotherapy, then there is a role of immunotherapy in advanced disease. If it is PDL1 positive, if the CPS score is raised more than 1, then we can consider pembrolizumab.
Which
with
trial
chemo.
showed that? Would you know?
Keynote A18.
Okay. So this patient is a 1B2 adenocarcinoma. So what do you want to do next, Dr. Abhishek?
Yes, ma'am. If the imaging findings are consistent with the 1B2 stage without any evidence of metastatic lesion, I will counsel the patient regarding further treatment options. I would like to go ahead with the radical hysterectomy plus bilateral pelvic lymph node dissection in this patient. Open radical hysterectomy.
Okay. What are the types of radical hysterectomy?
As per the Kirtley-Merrow classification of the 2018, it is divided into type A, B, C, and D. In the type A, it is similar to the extrafacial hysterectomy. We divide the parametria and the both uterocecal and vesico-uterine ligament close to the uterus and cervical lesion. In the type B, we divide it at the level of the ureter parametria, and we divide the uterocecal and vesico-uterine ligament in the midway between both the parts. It can be type B1 and type B2 depending on the paracervical lymph node removal. Then we have type C divided into type C1 and C2, that is nerve sparing and without nerve sparing. In which we mobilize the ureter laterally and will take the entire parametry along with it, and we divide the uterine artery at the origin from its internal iliac artery, and we take entire of the both anterior and posterior uterovaginal and uterovesical and uterosacral ligaments. And then we have type B, that is extended resection. That it is further divided into type D1 and D2. In D2, we also take the lateral pelvic wall muscles like obturator internus. And in the type D1, it extends beyond the iliac vessels. The parametria removed.
So can you just elaborate the steps of a type C1, Dr. Simran? Steps.
Ma'am, I'll take a midline, lower midline vertical incision. And then first, depending on, I'll open the round ligaments and then visualize the ureter. In type C1, ureteric tunnel is opened and
So what's the first thing you'll do? First thing, after opening the round ligaments?
Sorry, I'll inspect the organs and look for any lymphadenopathy or any metastatic disease in the abdomen. And if there are any suspicious lymph nodes, then I will section. If not, then I'll proceed with radical hysterectomy. So I'll open the round ligaments and then
where will you open the round ligaments?
At the in front of the sacral promontory.
Round ligament.
Sorry, that is retroperitoneum.
So round ligaments go from the uterus into the. Where
It's
do they go?
IP ligament, round ligament. Ma'am asking for round ligament.
Round ligament.
So you open the round ligament at near their exit from the pelvis, and then that is after that you open the spaces, retroperitoneal pelvic spaces. What are the spaces that you will be opening? Unless you open the spaces, you cannot see the vessels or the lymph nodes or ureter or anything.
Yes, ma'am. So there are paravesical spaces and the pararectal spaces, medial and lateral.
Okay.
So
Where are they?
paravesical is anteriorly. It is lateral to the
Boundaries of.
Boundaries of vesical space, paravesical space.
anteriorly pubic symphysis, laterally medially
Dr.
there is
Abhishek, do you want to?
Abhishek, can you try?
Yes, sir. We have one paravesical and pararectal space. The pararectal space is medially bound by the rectum. Anteriorly, we have cardinal ligaments. Posteriorly, we have sacrum, and laterally, we have iliac vessels. It is divided into two parts by passing of the ureter, that we say Okabayashi and large foot space, that is medial and lateral space. The paravesical space is medially bound by the urinary bladder, anteriorly pubic symphysis, posteriorly cardinal ligament, and laterally we have pelvic wall, obturator internus muscle.
Paravesical space?
Yes, sir, paravesical. Medially bladder, anteriorly pubic symphysis, posteriorly cardinal ligaments, and laterally we have obturator muscle.
Is it divided into medial and lateral?
Yes, sir. It is divided by obliterated umbilical artery into medial and lateral space.
So what is the importance of developing these spaces?
To preserve the nerve supply that we are doing in the C1 type of hysterectomy, the nerves in the inferior apogastric plexus, it lies in the Okabayashi space adjacent to the rectal region. And as we proceed towards the bladder, it lies in between the medial and lateral paravesical space.
So opening these spaces, define the parametrium, and clinically, how do you assess the parametrium? By parietal examination. Okay. Intraoperatively, how do you assess the parametrium? By keeping the index and middle finger on the inside the paravesical and pararectal space, you can palpate in between the two fingers. The parametrium can be assessed better during surgery.
Yes, sir.
Okay. That is why you need to first open the spaces, assess the parametrium, how much is whether it is involved or not, then proceed with the surgery. Then what will you do? So you have what other spaces are in and around the uterus? Paravesical, pararectal, then in the midline, anterior and posterior.
Between the uterus and rectum, we have, and the uterus and urinary bladder, we have utrovesical space and uterorectal pouch. We have both anterior and front. We develop plane in the both region to reach till the cervical lesion.
So you have to develop so that all these spaces helps to mark the boundaries of dissection. Then you can proceed. So how
what
do you manage?
What would be a lower limit for a nerve sparing radical hysterectomy? How will you spare the nerves?
Starting at the Okabayashi space, we'll identify meticulously and will lateralize the hypogastric nerves. As we move forward, will the inferior limit will be deep uterine vein. We want to go below the deep uterine vein to preserve the further branches going into the urinary bladder.
Yeah, so uterine artery is above the ureter and deep uterine vein is below the ureter. So that below that you should not go if you want preserving the nerves. Okay. So would you do sentinel lymph nodes for this case?
Usually sentinel lymph node biopsy are preferred for the tumor less than 2 centimeter in dimension, but it can be done till 4 centimeter dimension.
Yeah, which trial showed that?
Cervical, like multiple trials are there, Cervical 1, 2, and 3, which showed the efficacy of sentinel lymph node biopsy that can be done with equal oncological outcomes and decreased complications like lymphedema and suicide.
Yeah. So yeah, better for smaller tumors, but Cervical, they included tumors up to 4 centimeters.
Yes, ma'am.
What about minimally invasive surgery? What is the role of minimally invasive surgery? For this case, will you do?
No, ma'am.
Okay. Why?
As per the published trial LACC, we have higher rates of recurrence and lower disease-free survival associated with the laparoscopic surgery compared to the open surgery. So we like to perform open radical hysterectomy in this case.
Yeah, what is there any other trial which showed anything? Apart from LACC, was there any other trial you know of?
Comparing lab versus open, I know LACC on them.
SUCCO trial. Have you heard of the SUCCO trial? Simran?
Yes, ma'am.
What did it show?
It also showed the same thing, ma'am, that minimally invasive is inferior outcomes compared to open surgery in CA cervix.
So what were the reasons? What were the reasons for that?
Ma'am, because after in these trials, they found that there was a peritoneal disease which in recurrence, which was never seen in cervix before after doing minimally invasive.
Okay.
And also there was overall survival was decreased after doing minimally invasive compared to open surgery.
Yeah, but what were the reasons, stipulated reasons for this kind of?
Maybe because of the use of manipulator, there was dissemination of tumor cells in the peritoneal cavity. Because of CO2, there was more dissemination, and they also feel that because of colpotomy, there could be spillage of cells. So the recent trials which are being done, RACC and ROCC, they are trying to take these precautions that they've strictly avoided the use of uterine manipulators, and they are trying to staple or close the vagina before doing a colpotomy.
Yeah. Also, the radicality of the surgery was a question. Maybe, it was slightly less radical surgeries. So, yeah. Dr. Selvaraj?
Yes, minimally invasive surgery, we completely dependent on the thermal management of the dissection. Completely, no clamp tie is possible. So, because of the fear of thermal injury, we always guarded dissection. So, if we are able to use the clamp tie, we can be conveniently get additional margins. So, and the nerves are very filmy, not seen completely or even with the good magnification. That is why the failure rate is common. And the dissection structure, parametrium, is three-dimensional structure. It's very difficult to understand with minimally invasive 2D views, or even with 3D views, it is very difficult to assess. So clinically, you can palpate and give adequate margin. You can put additional margin by applying another one clamp like that. And the nerve preservation goes with minimal clamping multiple times, so you can get more amount of parametrium, not like applying two or one single clamp or two clamp on the parametrium, then there is a chance of high nerve injury. So all these things favor for the open surgery rather than So like rectum will be in a closed confined space. Dissection planes are very clear, so it is not so in CA surface. That is why the failure rate are common in minimally invasive surgeries.
Yeah, can we move the slide further? Stage. Okay, already done that. Okay, so that's the histopath report. Histopath, huh? So will she need any adjuvant therapy based on this histopath? Fastest finger first.
No, ma'am. According to the Sedley's criteria, if more than 2 out of 3 features, that is lymphovascular space invasion or stromal invasion more than 1/3 and size more than 4 centimeter, if more than 2 out of these 3 are present, then adjuvant radiation is needed. In this case, the size is less and there's no lymphovascular invasion. So she won't require any adjuvant radiation or chemo.
Okay. If she did require, what would you give her? Suppose she had like a 4 centimeter tumor and LVSI positive. What would she require?
She would require EBRT, external beam radiation therapy, and walled brachytherapy.
Wall brachytherapy is not necessary. Usually, EBRT alone, how much?
Total of 85 gray can be given combined.
No, this is post-op RT. This is not definitive CTRT. Okay, so that much dose is not given for adjuvant post-op RT. 85 to 90 is for a definitive when you're not doing a surgery. Okay,
So maybe 45 gray for adjuvant.
5 to 50 grays, yeah.
What is the difference between the pre-surgery radiotherapy and post-surgery radiotherapy regarding the morbidity?
So post-surgery, the morbidity is more so. That is
What
why.
type of morbidities and why?
There are more chances of lymphedema, more bladder dysfunction, more sexual dysfunction. And that is why we prefer single modality, either surgery or radiation or CTRT.
Any small bowel complications?
There can be
Can you explain why?
adhesions.
Yeah, so the small bowel will be fixed. So all the radiation will be given to same site of small bowel, so that will produce enteritis.
How will you follow up this patient? Dr. Abhishek, how will you follow this up?
I will like to do history and physical examination every 2 to 3 months for initial 2 years, followed by every 3 to 6 months.
Not 2 to 3. 3 months is fine.
3 months for first 2 years, then approx 6 monthly for upcoming 3 years. Both history and examination. And along with that, we can also take the cytology. Annual cytology will also do to rule out any further evidence of dysplasia or recurrence. And imaging can be done whenever there is a clinical suspicion of recurrence is there in form of PET-CT or CCT.
What kind of recurrence do you expect in this? What is the most common pattern of recurrence?
The most commonly, recurrence occurs in the pelvis region only, central pelvic recurrence. Other than that, there can be pelvic lymph nodal or periaortic lymph nodal recurrence, or there can be distant mets in form of lung mets or liver mets.
Yeah. And when do you expect that? When do most of these recurrences occur?
Pardon, can you repeat the question, please?
When is the time you expect these recurrences mostly?
The usually recurrences occur after like within 3 years, mostly around 2 to 3 years.
Yeah, within the first 2 years mostly. Okay. Okay, shall we go to the next case? Yeah, so this is a 70-year-old lady, again, multiparous, complaints of progressively increasing postmenopausal bleeding with history of bloating sensation and reduced appetite since a month. Okay. Clinical findings, nothing much on systemic examination. This is the findings on the local examination. 3 by 3 centimeter exophytic growth. Per anterior vagina is involved. Parametry are free. So what is this stage clinically?
Stage 2A, ma'am.
2A1 now. Okay, now
2A1.
it's 2A's 1 and 2. So this is 2A1. Okay. Then the MRI findings. So we've done a cervical biopsy, which is showing a poorly differentiated carcinoma. And IHC showed a large cell. So this is the MRI. You can read it. There is a 4 by 2 by 3 lesion, and there is a large external iliac lymph node. So what is the stage now?
3C1.
PC1.
3C1. So how will you proceed?
I will like to go ahead with some option of definitive chemo and radiation for the patient, plus brachytherapy. And the radiation part will be covering iliac lymph nodes also. So with a total dose of around 80 gray, with starting with the EBRT, I will give around 45 to 50 gray in around 28 fractions. With concurrent cisplatin, weekly cisplatin will give, followed by brachytherapy dose will give like 5 to 6 gray per fraction in 5 fractions.
Okay, what are the ways in which EBRT is given?
For this, like
Or
intensity.
planned, rather. Yeah.
Yes, ma'am. For intensity modulated radiotherapy, image guided radiotherapy, we take a CT images just before proceeding for every radiation part to accommodate for any changes related to the treatment. We do contouring before planning every fraction of the treatment. And intensity modulated had the advantage that we can spare the normal tissue from the side effect of the radiation. We can limit the radiation to the affected part only. So on that EBRT, then we have brachytherapy specifically for the cervix.
And what is the time duration in which we should finish the treatment?
Approximately 6
7
weeks.
weeks.
Within 8 weeks maximum. Dr. Selvaraj, I would like to ask you.
Nothing much.
Okay, so is there a role of any chemotherapy in this scenario?
Nowadays, due to upcoming trial in advanced cases, we can start with NACT, followed by definitive CTRT protocol completion. There have been a trial, interlaced trial that has given 6 cycles of paclitaxel followed by definitive CTRT that has shown to improve overall survival and disease-free survival in this category of the patients.
How was the chemo given? What was it?
Paclitaxel and carboplatin, 6 cycles.
How often?
What is the
Weekly.
criteria to choose this?
Sorry, sir, I was not able to hear your question.
Dr. Selvaraj, I think there's some connectivity issue from your end. Can you just try once putting your camera off? I'll just stop the video from my end. Hello, Dr. Selviraj? Yeah, I think he's frozen, Dr. Priya. Please go ahead.
Yeah, so what was the chemo you said? How was it given? How often and what? Back.
Weekly fractions were weekly cycles of chemo was given for 6 cycles. Advanced diseases like in this trial they have taken stage 4A, stage 3, stage 2B cases.
What was excluded?
If there was invasion of lower 1/3 of vagina and
Parietic nodes also, they will include the parietic node.
3C2 and 2A.
So that's one of the problems with that trial. They excluded the parietic nodes. And what are the other problems?
I'm not aware.
Increased toxicity, ma'am.
Yeah, so because of the chemotherapy, the dropout rates may be high compared to, were higher compared to, I mean, if you were not giving that. So some patients would not be able to complete the CCRT, which is actually the definitive treatment because of toxicity of the chemo. And what else? So this trial was done over a long period of 10 years, and older radiation techniques were there, and the survival in the radiation arm itself is not so great compared to what we get today with the techniques today. So those are the main problems with that. But again, if you don't have access to, if the patient is having to wait for radiation for a few weeks or a month or so, then this is something that can be used, neoadjuvant chemotherapy before CCRT. What is the other trial? Is there any other trial about chemo and cervix? Adjuvant chemo.
Outback trial.
Okay.
Their CCRT is followed by adjuvant chemo.
What did that show? That didn't show any benefit. Okay. Outback trial did not show any benefit of giving adjuvant chemotherapy. That was a normal, like a 3-weekly adjuvant chemotherapy. Okay. Then what is the next slide? Can you describe this one? The first image.
It's a sagittal MRI showing a lesion in the cervix reaching up to upper vagina, and fat planes are maintained with the bladder and rectum.
What else can you appreciate in the other images?
Simran, can you continue describing the MRI?
Yes, ma'am. I'm not sure what it's.
Comment on the structures. Usually what we see, parametrium.
How do you see parametrial involvement in MRI? Which section and what will you look for?
In axial section, it is better to look for the parametrial involvement.
Okay. What do you look for?
Dr. Abhishek, can you describe the MRI if you know the findings?
Yes, ma'am. As ma'am previously described, we'll like to assess the location of the lesion, that is cervical lesion, and the planes along the rectum and anteriorly along the urinary bladder. The lesion seems to be involving lower 1/3 of vagina. And in the another section, the axial section, coronal section also, the fat planes between the cervix and anteriorly bladder and posterior rectum appears to be maintained. There is one lymph node seen in the middle image in the region of the right iliac region.
Yeah. So how do you assess parametrum? Same question. So the dark cervical stromal ring will be breached on, that is how you will know the lateral parametrum is involved.
Okay.
How do you assess involved nodes?
As per imaging, we'll look for suspicious node, like they have become round in shape instead of elongated. The enlarged short axis diameter more than a centimeter. If there any presence of necrosis is there.
Which axis? Which axis?
Short axis diameter more than 1 centimeter, sir.
Then?
Presence of necrosis, or is the adjoining infiltration into adjoining structure. Look for ENE. So
External extension.
Yeah, external extension. Yes, sir.
Okay.
So is there any role of para-aortic surgical staging in this patient before starting CCRT? This is a case actually you could use PET-CT, But anyway, is there a role for surgical staging of para-aortic nodes?
In this case, we'll go for definitely CTRT, and if the para-aortic nodes are enlarged or look suspicion on PET-CT, then we can give extended field RT.
And there's a trial called Lilac trial where they did surgical staging and they said it is superior to PET staging before going ahead with.
Lilac is published? I don't think so. It's ongoing, I think. It's ongoing, but there was a trial in which they looked at whether MRI was better than PET-CT was not looked at. So what they found is surgical staging was did have better outcomes, survival outcomes. But again, it has its own complications and cost and delay of the treatment and all those other things are there. So you have to balance the risk versus benefit. Yeah. And PET-CT is fairly good at. What is the other use of PET-CT in CA cervix? One is to do metastatic evaluation. What else?
During
For this
treatment?
case specifically. Response assessment.
During therapy response assessment.
Yes, sir. Post CTRT, we can repeat it after like 6 to 8 weeks to look for the residual disease.
6 to 8 weeks might be too early. Yeah. RT-related changes will be there till 2 to 3 months, maybe up to 6 months.
And sometimes the MRI, it will be difficult whether it's a scar or recurrence. So during that time, PET-CT will help. On follow-up also. Early detection of recurrence.
So is there any parameter they use on PET-CT? How do you know?
Metabolic activity.
Yeah, so the ratio of pre and post-treatment metabolic activity of the lesion, okay? Okay, can we go to the next one? Thanks. This is a summary. Okay. Oh, so it's already done. Are we going okay? Are we too fast, too slow? Please let us know.
Yeah, I think we have about 10 minutes for the case discussion.
Okay.
I think for this case, we have about 10 minutes. Thank you.
Okay. So this lady is a 63-year-old lady. She was diagnosed with a squamous cell carcinoma in 2019, 2B. She received definitive CCRT, and she was lost to follow-up after that. And after a DFI of 4 years, 9 months, she came with complaints of abdominal pain and bloating sensation. Next. Okay, nothing very specific in general systemic examination. Abdomen, there was a solid mass with ill-defined borders felt in the hypogastric region. So what could this be? What could this mass be? Dr. Abhishek.
Yes, ma'am. As this is palpable in the hypogastric and lumbar region, this can be a lymph nodal mass that can be there, or as the CDRT was only given, so there might be a recurrence of the lesion.
Can you really, lymph nodal masses will usually not be palpable like this, no? Unless it's really, I mean, that's unusual.
It must be the same tumor of the cervix which has probably extended to the uterus.
Where is it now? This is in hypogastric region. Okay, so it could be an omental mass, it could be, some kind of mets. Next, what is it? Local examination. So there is a mass palpable over cervix as well, and right parametrium is infiltrated, extending up to the right lateral pelvic wall, and left also is involved, but not so laterally. So how will you proceed with evaluating this patient further?
We'll like to go ahead with the first for systemic staging and systemic meds. I would like to do the PET-CT imaging for look for any evidence of synchronous metastatic lesion in the lung, liver, or in the peritoneum. And if there is no metastatic disease elsewhere other than this local lesion, we can go ahead with the MRI for definitive characterization of the lesion, involvement of the right lateral pelvic wall, as can be evident clinically. To look for resectability. If it is a resectable, then we can plan pelvic exentration procedures in such a scenario. And if it is a not unresectable disease, then we like to go ahead with CTRT again, because it had a DFI of almost 4 years.
Okay. So what would make it unresectable in this findings?
Involvement of lateral pelvic wall, if there is unresectable disease involving the blood vessel, iliac vessels, bony involvement is there.
What is the terrible triad? If you have the terrible triad, you must not, you must avoid exentration.
I'm not aware of.
It's a symptom complex. Okay. So, yeah, this doesn't seem to be a case for exentration because it's going right up to the right lateral pelvic wall. So, what did we find we found in the PET-CT that there were, can we have the next slide? Yeah, so there were abdominal mets, peritoneal mets, liver mets. So what would you do for this patient?
In such a scenario, we'll like to go ahead with palliative systemic therapy. We'll start with the patient on the palliative chemo based on paclitaxel carboplatin we can give. And as per the recent evidence, we can add pembrolizumab also for this patient.
And anything else?
For local control, EBRT can be given if there is symptoms of vessel compression, lymphedema in the lower limb.
Bevacizumab you can give. Pembrolizumab is
Yes,
cost.
bevacizumab, yes, can be given.
Get bevacizumab also. Dr. Selvaraj? Anything?
So, any role of palliative procedure, surgical procedure, not for this case, but inoperable cases. Locally advanced, inoperable case, any palliative surgical procedure.
The divergence we can do if there is an involvement of ureter and associated hydronephrosis is there, we can urinary diversion by using like PCN can be done. If there is associated bowel obstruction involving maybe small bowel, large bowel, then stoma can be made for palliation of that symptom.
Fistulation and leak.
Yes.
So quality of life will be improved by diversion procedures. If it is not extensive intra-abdominal spread like this, you can try diversion of urine, diversion of motion. So continuous leaking perineum, the patient will suffer more. So if the life expectancy is more than 3 months, you can try surgical procedures, or stenting or PCN can be done for very short duration of life expectancy.
Yes.
So how long do you expect this patient to live? What is the prognosis?
For like this is a stage 4B disease. So for some 5-year overall survival is less than around 15%.
This is not 4B, this is a recurrence. So
Okay. All right.
How do you stage during recurrence? By current disease or previous diagnosed disease?
So by current disease status, whether it's like loco-regionally advanced or systemic metastasis.
Would you consider stenting of the ureter in this case?
Yes, I will consider for stenting at least in the right side because it was reaching till right lateral pelvic wall.
What will you achieve by doing stenting?
So the kidneys will ultimately go into failure to.
So you can preserve the renal function. So
Yes.
chemotherapy can be given.
Can be given. Yes.
Otherwise, in uremic patients, the hope of chemotherapeutic agents will be very less. So whenever possible, better to stent prophylactically so that you can continue the chemotherapy during the palliative care.
yeah, I think it's all right.
Okay. So thank you both examiners and both examinees. I think we have Dr. Sameer Gupta with us. So before we go to Dr. Selvaraj's talk, we have Dr. Sameer Gupta online.
Yeah, I am.
Yeah, just wait a minute. So Dr. Sameer Gupta is part of the organizing team. He's the organizing secretary for IASO NatCon 2026. And over to you, Dr. Sameer.
Hi, thank you, Dr. Srijan and Dr. Viva, for this good opportunity to reach out to all the young trainees surgical oncology. Can I request Dr. Viva to play the slide
It's
that
there.
we have? Yeah.
Yeah, it's there.
Okay, yeah, it's there. Yeah. So I'd like to welcome you all for this ISO NatCon 2026. The dates proposed are 8th, 9th, 10th, and 11th October. 8th, we have dedicated workshops, and we are planning 6 to 7 workshops, and we are trying for some hands-on cadaveric thing also for pelvic dissections and for thoracic surgery. along with some dedicated workshop on the use of AI tools in surgical oncology, how to get ahead of the train, if I may call it. And 9th, 10th, and 11th October, we have the main conference. It is at Lucknow. And this is a special occasion because we'll be celebrating 50 years of IASO. So we would like to revisit the glorious journey of ISO through the years. We propose to have all the past presidents in attendance, and we're trying to chalk up a good program in consultation with the ISO EC president and secretary. And I assure all the trainees that will be a very good opportunity. There are a lot of exciting fellowship awards on offer. ISO offers more than 20 fellowship awards, opportunity to attend SSO, ESSO, Brazilian conference, and many more awards. And in addition to that, we have a lot of cash prizes to be won for best poster, paper, video, and I promise it'll be a very good exposure to all. So I welcome everybody wholeheartedly for this conference. We are about to open abstract submission in next fortnight, hopefully within this financial year, before 31st March. So once the abstracts open, I would suggest everybody to put in their best foot forward because there are lots of prizes to be won. And looking forward to welcome you all in Lucknow. In addition to the academics, we promise it to be a gastronomic delight. People at Hyderabad would not appreciate it that much because it is also a city of kebabs and biryani. But for rest of India, I'm sure they should be looking forward to some real gastronomic delight. So yeah, I think we have the screen, we have the QR code as well. So I would request everybody to register as soon as they can. Thank you. Thank you, Dr. Sridhar.
Thank you, Dr. Samir.
And Dr. Ziba, yeah, thank you.
Thank you.
Bye.
We move on to the next segment of the masterclass, which is the expert talk. Today we have Dr. Selvaraj, who will be presenting on the contemporary management of cervical cancer. Dr. Selvaraj, if you could share your screen.
Yes.
We see your screen and we see learning objective as the slide. Yeah, great. Over to you, Dr. Selvaraj.
Good evening to all. So this presentation is about the comprehensive review of the cancer cervix. So we are already have discussed many things. So this presentation will give importance to some surgical anatomy techniques and options. So it's a common cancer among women worldwide. And this is the presentation about the incidence of cancer cervix in various states of India. So few states still have high incidence rate because of high prevalence of human papilloma virus as well as poor screening and follow-up of precancerous lesions. So the risk factors are HPV infection, immunosuppression, early marriage, multiparity, smoking, and poor genital hygiene. And pathogenesis. So after the infection, CAN develops, then in situ malignancy, and then invasive carcinoma. This is a very long duration of pathogenesis. And high risk sign in colposcopy are dense acetoid epithelium, coarse punctation, coarse mosaic pattern, and atypical vessels, which is highly suspicious for invasive cancer. And sharp demarcation line, inner border sign, ridge sign, and iodine negative areas. So how many years before cancer risk can be detected? So the development of CAN takes 1 to 2 years, and then development of CAN 2-3 over next 3 to 5 years, and invasive cancer maybe around 5 to 15 years. So we have very long window which can be utilized for better screening, and we can prevent cancer cervix by increasing the more screening centers. So we have many treating centers now, but screening centers are very less. That is why this big gap. So we can reduce the incidence by proper screening. And among CAN, mostly 60% are regression to complete, and progression to invasive malignancy is around 1%. So CAN2 around 5% invasive cancer, and CAN3 around 12% develops into invasive malignancy. So histological subtypes are squamous cell, adenosquamous, and neuroendocrine, and clear cell carcinoma. Neuroendocrine carcinoma has highly aggressive and early nodal and distant metastasis. Clinical presentation, we have discussed many things, and clinical examination part also, and staging, everyone knows. The latest update has substaging in 1B and 3C, so subdivisions, and it gives more importance for the depth of invasion rather than horizontal spread. And investigations part, we have discussed extensively. The parametrial nodes, obturator nodes are commonly involved, internal iliac and external iliac nodes. Sometimes parietic nodes are involved. The nodal involvement by stage, as the stage increases, the incidence of nodal disease increases. A1 has 1.1%, and A2 with LVSI, it is around 2.5 to 5.5%. So the stage increases, nodal involvement also increases. So important surgical anatomy, we have to be more cautious about the ureter, hypogastric nerve, pelvic splanchnic nerves, uterine artery, and parametrial dealing. So these pelvic surgical spaces helps to identify the nerves, preserve the nerve. So these spaces are medial paravesical space, and then medial pararectal space, Wakabayashi space, lateral pararectal space, Latsko space, and Yabukis fourth space. It is a potential avascular space to lateralize the dorsal layer of vesicouterine ligament, which contains a nerve branch to bladder. So history of treatment, it starts with radium brachytherapy, radiotherapy, and then concurrent chemoradiation about the medical management. But surgically, first radical hysterectomy introduced by Worthims in 1911. Then three major modifications were made in the coming years. Latsko, because of high morbidity with the radical hysterectomy described by Worthims, Latsko reduced the radicality by reducing the parametrial dissection. Wakabayashi introduced the ureteric dissection technique, and oncologically safe as well as radicality maintained. Meeks, he added systematic pelvic lymphadenectomy in this procedure. And then comes the fertility preserving surgery introduced by Dargent by radical trachelectomy. He used a vaginal approach, and then laparoscopically he managed the lymphadenectomy part. And then now more interest thrown on the nerve sparing radical hysterectomy for better bladder, bowel, and sexual function in the patient. So current treatment principles are based on the treatment, depends on the staging, like tumor size, node status, and desire to fertility and performance stages. So surgical options, the stage-wise surgical options are 1A1 with main treatment will be cone biopsy, and fertility desired patients, the conization is adequate if the margin is more than 1 millimeter, or simple trachelectomy is adequate. 1A1 with LVSI, so main treatment will be if the margin is negative, then type A hysterectomy, margin is positive, type B hysterectomy, both with pelvic lymph node dissection. And for fertility desired patients, the same like conization or simple trachelectomy, added lymph node dissection. And then 1A2 radical hysterectomy, pelvic lymph node dissection. For fertility preservation, radical trachelectomy with pelvic node dissection. 1B1 same treatment. 1B2, if the size is between the 2 to 4 centimeter, we can we can do surgery or chemoradiation if high risk surgical factors. These high risk surgical factors can be assessed by imaging also. So if you suspect any nodal involvement on imaging, or probability of positive margin with surgery is high, or suspicious parametrial invasion, in the imaging, and the larger tumor size and the deep stromal invasion and the LVSI and the biopsy, cone biopsy segment, then prefer for chemoradiation in 1B2. 1B3 is always chemoradiation. 2A, if it is less than 4 centimeter, you can consider surgery. More than 4 centimeter, go for chemoradiation. Then 2B, 3, 4A, all were treated with chemoradiation. If there is any central recurrence, excitation can be considered. 4B, distant metastasis, so systemic therapy is the only option. And when there is a recurrence, you can differentiate between the recurrence and second primary by if the recurrence is after 5 years and with a different anatomical location, different histological type, or independent pattern of growth, you can suspect second primary rather than recurrence. Recurrence is usually happens between 2 to 3 years period, and genetic molecular profile may be different in second primary compared to recurrence. So recurrence may be central, pelvic, regional, distant. Central recurrence can be treated with pelvic excitation if the patient is suitable patient. And difference in treatment strategy for HPV positive and negative. Usually HPV negative is less common and associated with the gastric type of adenocarcinoma, clear cell, mesonephric types, and they have multiple mutations like TP53, P10, KRAS, and they are relatively resistant to chemoradiation, more aggressive disease. So they need more aggressive surgical approach rather than systemic therapy, because high failure rate with the systemic therapy, and immunotherapy also has variable response. So recurrence pattern will be more frequent distant metastasis, but in HPV positive patients, the tumor biology is E6, E7 protein oncogenesis, better response with radiotherapy and chemotherapy, better survival, and better response to bevacizumab and pembrolizumab. And radical hysterectomy, this is an older classification. Newer classification with type A, B, and C1 nerve sparing, C2 non-nerve sparing, and D is laterally extended resection. So steps of nerve sparing radical hysterectomy. First, we do paravesical and large scope space exploration, then assess the parametrial involvement, then pelvic lymphadenectomy. If there is any suspicious nodes, send for frozen section, and then Wakabayashi space developed by defining the ureter, and define the uretero-hypogastric fascia, which contains the hypogastric nerves. Then deal with the uterine artery, ligate at the origin, and then medialize it. Then parametrial excision with multiple small sized clamps. So don't apply one big clamp, one or two clamp technique. So that should be in a horizontal plane parallel to the nerves. And deep uterine vein and its tributaries are identified, individually clamped, cut, ligated. Then after proper dealing the parametrium, colpotomy with adequate margin achieved. So this picture to describe the Wakabayashi space, medial pararectal and lateral pararectal space and paravesical space. And the bladder innervation with the parasympathetic nerve, which is responsible for emptying, that is contraction of the detrusor muscle from S2, 3, 4 root level. Sympathetic and somatic both are responsible for relaxation of the detrusor and storage of the urine. So this picture shows clear about the sympathetic, parasympathetic, and somatic nerve supply. And hypogastric nerve is in the rectal side wall, uretero-hypogastric fascia, which contains the nerve, hypogastric nerve, which is 2 to 3 centimeter below. This is a picture of male pelvis. So this is ureter, 2 to 3 centimeter below left hypogastric nerve. Then inferior hypogastric plexus formed by combining sympathetic and parasympathetic sacral plexus. Then it gives branches to the bladder, then prostate, or in females uterus and cervix, then rectum. These three branches will come out of the inferior hypogastric plexus. If the inferior hypogastric plexus damaged, both sympathetic parasympathetic will be getting affected. So this picture shows this is the superior hypogastric plexus, right hypogastric nerve, and pelvic splanchnic nerves forms the inferior hypogastric plexus at the level of deep uterine vein. Then it gives branches to the bladder, uterovaginal and rectal branches. So uterovaginal plexus can be cut off, but it is very close to the uterosacral and cardinal ligaments. During clamping and cutting, it may get affect adjacent nerve structures also. So too much vigorous pulling and applying big clamps may damage hypogastric plexus itself. The inferior hypogastric plexus lies posterior to the deep uterine vein. During ligation of the deep uterine vein, the plexus lies just posterior. So careless dissection and applying the clamps may damage the plexus itself. So possible nerve injuries, this picture clearly shows. During division of the uterosacral, hypogastric nerve at risk. During division of the deep uterine vein, this is the deep uterine vein. During clamping and cutting, the danger of cutting the pelvic splanchnic nerve as well as inferior hypogastric plexus. So nerve injury at this level. And then division of rectovaginal ligament here and ligation of division of the paracarpium here, both will damage bladder branches if it is clamp is well advanced. So this picture shows the relationship. So this is superficial uterine vein. So the two tributaries of superficial, one is vertically placed posterior to the uterine artery, commonly seen during laparoscopy as well as open procedures. And superficial, another tributary is the anterior part, which drains the bladder as well as the vaginal part. So this dorsal part of the bladder pillar contains the bladder branch. So damaging this part is common when we advance the clamp in this direction. So this is Vardim's method of applying the clamp, Meek's method of applying the clamps, and Okabayashi's method of applying the clamps. So bladder pillar has two layers, ventral layer of vesico-uterine ligament, otherwise called bladder pillar. So this ventral layer is anterior and medial part of the ureter covered by this anterior pillar. So it contains superior vesical vein and cervico-vesical vessels. These vessels are very close to the ureter. So during laparoscopy procedures, we rely on the thermal control of these veins. Then there is a damage to the sublethal thermal damage, and later leak on 5th or 7th day from the ureter can happen. And dorsal layer of the bladder pillar contains the nerve branches to the bladder. So this may get damaged for too much handling of the dorsal layer. So always deal with the ventral layer of the vesico-uterine ligament. Careful during dissection of the dorsal layer. So this picture shows the ventral layer. So ventral layer of vesico-uterine ligament, you can see it is intact. So carefully release it and lateralize the ureter. So ureter lateralize, then you can see the dorsal paracervix, that is posterior leaflet of the bladder pillar. So here is the bladder branches are going, and inferior vesical veins. This is superficial vein, and cervico-vesical vessels running on the anterior bladder pillar can be seen in this picture. So this another picture shows for orientation. This is cut ligated uterine artery, superficial uterine vein. Then paracarpium contains vaginal veins. So inferior vesical veins are cut. This two cut ends of the inferior vesical veins. Then cut end of deep uterine vein. This is the deep uterine vein cut here. So inferior vesical vein. So individually clamp and cut all these veins so that these nerve branches are not getting injured during dissection. After proper dissection, you can see T-shaped residual nerve. This is sympathetic. This is parasympathetic. This is bladder branch. So T-shaped nerves will be preserved. So this is about the nerve sparing radical hysterectomy. So minimally invasive surgery is not advised now because LACC trial showed inferior outcome compared to the open surgery. So advanced disease treatment is chemoradiation, palliative chemotherapy, and immunotherapy. Then comes in recent days fertility preserving treatment. You can consider fertility preserving treatment for the lesions less than 2 centimeter, depth of invasion less than 10 millimeter, without any nodes on the imaging, And grade squamous cell carcinoma, any grade, but adenocarcinoma, usual type adenocarcinoma, grade 1 and 2 only you can consider, and without LVSI, and these are all the indications to consider fertility preserving. So procedures will be conization or radical trachelectomy. So radical trachelectomy means removal of cervix and parametrium, preservation of the uterine body. Lymph nodes can be dealt with open or laparoscopic method. This allows pregnancy, but outcome will be 60 to 70% live birth rate after fertility preserving surgery. The failure of fertility preservation comes when the tumor size is more than 2 centimeter, node positivity, and deep stromal invasion. Radiation has a big effect on the fertility. So ovaries will be like postmenopausal stage because of ovarian failure even after 2 to 6 grade. That is the lethal dose for ovaries. Uterus, cervix, vagina all goes for fibrosis and stenosis. So fertility is very rare after radiotherapy. So sentinel lymph node mapping is the best reduction rates are with lesions less than 2 centimeter. And extended field radiotherapy is advised when the parietic nodes are positive by imaging or confirmed on pathology, and it can also be considered for any pelvic lymph nodes like common iliac nodes metastasis present. And there is no role for conservative surgery for small cell neuroendocrine tumors. So radical cystectomy for less than 4 centimeter lesion with pelvic lymph node dissection with or without parietic node sampling, and chemoradiation for more than 4 centimeter size tumors with cisplatin etoposide 4 cycles. And what findings you will be interested in postoperative HPV is tumor size, histological type, and HPV association, and grade, LVSI, perineural invasion, and stromal invasion, the depth of invasion in millimeter divided by cervical wall thickness, so that percentage of the stromal invasion can be accurately assessed. Then tumor width, nodal involvement, and surgical margin status. If it is negative, the closest margin should be mentioned in the report, and if it is positive, the location of positive margin should be mentioned in the postoperative report. Additional molecular testing and biomarkers like PDL1 and HER2 immunohistochemistry, all these can be done for cases of advanced metastatic or recurrent cervical carcinoma. So we can plan for targeted therapies with these details, and HPV status for all cervical adenocarcinoma must be done. And regarding the HPV status, most squamous cell carcinoma are HPV related, especially HPV 16 and 18. P16 immunostaining is the key diagnostic marker for HPV associated tumors. And HPV independent tumors is rare, and it occurs in the elderly person around 7th decade. And molecular alteration like TP53, KRAS, and PTEN are there, and it is usually a keratinizing type. HPV associated squamous cell carcinoma usually non-keratinizing or basaloid pattern malignancy. For adenocarcinoma, HPV associated tumors are usual type of adenocarcinoma, villo-glandular, micropapillary, or mucinous type. And micropapillary has aggressive potential, and HPV independent gastric type, muconephric type, clear cell carcinoma, and endometrioid carcinoma. Gastric type is usually P16 negative, and clear cell carcinoma associated with DEC exposure. So for adenocarcinoma cervix, based on the gland differentiation, Silva pattern classification, the pattern A, B, C, and pattern A and B without LVSI is good prognosis. Pattern B with LVSI and pattern C are poor prognostic identification markers. And how do you differentiate between the endocervical adenocarcinoma and endometrial adenocarcinoma? Endometrial adenocarcinoma will have ER positive and Vimentin positive, and cervical adenocarcinoma CEA positive and P16 positive. So surgical complication, everyone knows, bladder morbidity, bowel morbidity. So surgery versus radiotherapy. Surgery preferred in early stage, radiotherapy for locally advanced disease. Fertility preservation possible only with the surgery. And even radiotherapy has its own morbidity like acute and chronic cystitis, proctitis, rectal ulcer, and vaginal stenosis. By stage, survival will be 80 to 95% for stage 1, 60 to 75% for stage 2, 30 to 50% for stage 3, and less than 20% for stage 4. So how do you prevent cervical cancer? By HPV vaccination, pap smear screening, via screening, and HPV DNA testing. Now, L1 vaccines are available, but L2 vaccines are developing stage to provide broader cross-type protection. And 9-valent, quadrivalent, and bivalent vaccines are available. The schedule of giving vaccination is for less than 14 years, 2 doses, 15 to 45 years, 3 doses series, and immunocompromised persons, always 3 doses. So key take home messages: cervical cancer is preventable. Screening and vaccination are essential part so that we can prevent this cancer from our society. Early stage treated with surgery, locally advanced treated with chemoradiation. Thank you.
Thank you very much, Dr. Selvaraj. There are a few questions that is there in the chat box that we would like to ask both of you. Just give me a moment. Can you stop sharing your screen, sir?
Yeah.
Yeah. So, Dr. Priya, if there is a carcinoma cervix with synchronous adnexal masses on imaging, how should we approach them? Dr. Priya, are you there? Dr. Selvaraj, would you like to take this question?
What is the question?
In carcinoma cervix with synchronous adnexal masses on imaging, how should we approach them?
So radiological criteria and tumor markers can be assessed, and if it is more towards malignancy without any spread, if the adnexal mass looks like a stage 1A, 1B, we can remove it and then deal with the CA cervix based on the staging.
Okay, so if the
If the
patient
surgery
requires...
is spontaneous, if it is a chemoradiation for cervix, bilateral salpingo-oophorectomy and radiotherapy.
Right. And in view of the SHAPE trial results, can we still offer minimal invasive surgery to tumors less than 2 centimeters, sir?
Yeah, if we are.
I think, yeah, it's reasonable now to offer minimal access.
The only problem is we need to have a very accurate assessment of the pre-op size and everything. That is the main problem.
Okay.
That's one thing. We would end up with a 3 centimeter tumor sometimes, and we would have done only a hysterectomy. So that is not a scenario you want to land.
Oh, okay. And how often are we offering ovarian transposition to premenopausal women with the carcinoma cervix who are going for radiation?
Not very common. Most of our patients are not that young. They're in their 40s, late 40s and 50s. So most of the time it's not really required. Yeah.
Okay.
But if the patient is very young and if the ovarian failure going to affect their bone health, then we can consider. But in the perimenopausal stage, it is not necessary.
Okay. Okay. And we see this very frequently. If there is bladder involvement noted on imaging or on cystoscopy, will it be safe to give brachy with definitive CRT, or do you routinely counsel for exenteration?
So unless there is a fistula,
Yeah. Yes, ma'am. Sure. You can speak.
So unless there is a fistula, upfront exenteration is not indicated. I think only just a bladder involvement does not require exenteration. Does not necessitate exenteration.
Okay. Dr. Selvaraj, do you have any other view? Or who do we offer exenteration to?
So exenteration is classically for salvage.
Yeah, recurrence.
Post-radiotherapy or residual disease or recurrence, Central recurrence, we offer as a salvage therapy, not as an upfront surgery.
Select cases of 4A, like when there is an obvious fistula.
Yeah. So with fistula will not heal. Actually, it will go bigger with the radiotherapy. So we can consider. So fistula is there, then upfront surgery is acceptable.
Okay. Okay. Thank you to both the examiners. I invite now the IASO member, Dr. Arnav Bandopadhyay, to give the vote of thanks and to wrap this session.
Thank you, Dr. Deva. We would like to thank Dr. Selvaraj and Dr. Priya on behalf of IASO Executive Committee and organizers. It was an excellent session, and I believe both the examiners have done well. Both the examinees, Dr. Abhishek and Dr. Sindra. I would also like to thank the Masterclass coordinator, Dr. Srijan and Dr. Zeva. They have done an excellent. It was the 71st chapter, if I am not wrong. So
Yes.
Masterclass is doing well. I believe the examinees and all of us who are attending will immensely. It is helpful for us also to revise and for the examinees also. I thank you all on behalf of IASO. Dr. Subbiah, sir, are you there? Would you like to say something?
Yeah, I don't think he is there right now. So yeah. I think we can conclude the session, and we'll be looking. Yeah, we will look forward to joining again for the Mastery of Surgery Chapter 10 on cervical cancer, where we will be showing MRI imaging and surgical steps on the 31st of March. And next month will be discussion on oral cancer. Thank you so much and have a great evening. Yeah.
Thank you.
Thank you.
Thank you. Thanks.